Hello, everyone. I'm Carmen Whiten, the principal of Ripple Enterprises and founder of the Women's Health Coalition of Canada. I am thrilled to serve as your moderator today for today's program. I would like to thank all of you for joining us and supporting this continuing medical education webinar presented by HPV Global Action and the Consortium of Infectious Disease Control. Today's presentation is entitled Advancing Cervical Cancer Prevention, Global Evidence, Self-Sampling Insights, and Implications for Canada. We are very fortunate to have two experts, Mateka Rabol and Teresa Norris, to provide this very important presentation. I would like to thank Hologic, whose support has enabled this webinar to be provided at no cost to attendees. In today's webinar, our presenters will address the learning objectives that you can see on the screen. Please note that this webinar is being recorded, and the recording as well as the PowerPoint slides will be made available following the webinar on CIDC's and HPV Global Action's websites. The addresses are displayed at the bottom of the screen. This recording, along with recordings from past webinars and other useful resources, may be found on both websites. You can also join the Canadian HPV Prevention Network by completing the contact form on the CIDC website. Now for some quick administrative notes. You can hear the audio via your computer speakers. All participants have joined the webinar in listen-only mode. To ask a question at any time during the webinar, click on the questions icon, type your question in the questions panel, and click the send button. Questions submitted during the webinar will be saved. All or some of the questions will be answered following the presentation during the Q&A period. Finally, we hope that all participants will complete the webinar evaluation. On this slide, you can see the link to the brief evaluation survey. If you registered and logged in with your own email address, you will be sent an email following the webinar with the survey link. Otherwise, please take note of this address on the screen. I would now like to introduce today's speaker, Mateka Rabol. Mateka is a senior epidemiologist at the Wolfson Institute of Population Health at Queen Mary University of London. With over 20 years of experience, her work focuses on evaluating cancer screening programs using patient-level data to inform evidence-based policy decisions. She has held research and advisory roles across the Netherlands, Denmark, and the United Kingdom, and has served as an expert advisor to the English NHS cervical screening program on technology, implementation, and research strategy. Mateka, over to you.
Thank you very much, Carmen. What a nice introduction. And good afternoon, everyone. And thank you to HPV Global Action for inviting me to speak today. I'll be talking about some exciting developments in cervical cancer screening, in particular the move towards HPV testing and the implementation of HPV self-sampling. Next slide, please. Before moving on, I'd like to acknowledge that I will use the term women as a shorthand, while recognizing that this includes all women and other people with a cervix. Next slide, please. So in Canada, cervical cancer incidence declined substantially in the period between 1984 to around 2005, after which progress stalled and rates became more variable. So much so that very recently cervical cancer has been identified as the fastest increasing cancer among women. Despite this year-on-year variability, incidence remains above the elimination threshold of 4 cases per 100,000. This means that more needs to be done to prevent cervical cancer, both by increasing HPV vaccination and by improving screening. Next slide, please. So today I'll focus on cervical cancer screening. For decades, screening has been based on cervical cytology, often known as the PEP test. It works by detecting early precancerous changes and removing them before cancer develops. This approach is very effective, especially when screening is repeated regularly. This is typically defined as every 3 years. While I don't have equivalent data for Canada, I'd like to show you an example from England, which has a population about 40% larger. At present, around 700 women die from cervical cancer in England each year. Without screening, it has been estimated that this number would be closer to 2,500. So this means that screening has reduced cervical cancer deaths by about 70%. But even so, there's still room for improvement. If all eligible women attended screening, the number of deaths could be reduced further by around 200 to 300 each year. Next slide, please. So more recently, many cervical screening programs have started replacing cytology with HPV testing. This is mainly because HPV testing is better at identifying women with pre-invasive lesions. For example, in England, we found that commercially available but validated HPV tests detect about 60% more CIN2 plus lesions and 50% more CIN3 lesions than cytology, even when cytology is well quality controlled. But there are two main reasons why this takes place. First, HPV testing helps detect cytological abnormalities earlier. When laboratory staff know that a sample is HPV positive, this can guide how they interpret the cells on the slide. This is a very well-known phenomenon, which we call informed reading. Second, women who test HPV positive but have no visible cytological abnormalities are followed up more closely. Instead of returning after 3 years, as they would with cytology screening, they're asked to come back sooner, typically within 6 to 12 months for another test. Next slide, please. For some time, there was uncertainty about whether detecting more precancerous lesions with HPV testing was actually beneficial. But we now have strong evidence from large studies across several countries showing that it is. When HPV testing identifies more high-grade pre-invasive lesions early, fewer are missed in women who test negative. This means fewer lesions are left behind to develop into cancer before the next screening round. You can see this all in the figures on this slide. The risk of cervical cancer after a negative test is consistently lower with HPV testing than with cytology. The risk after a negative cytology test was already low, but HPV testing reduces it further by another 50 to 70%. Next slide, please. So to summarize, HPV testing helps detect abnormal changes earlier. This allows earlier treatment of pre-invasive lesions and prevents cancer in some women who would have been missed by cytology. Because the risk of cancer after a negative HPV test stays low for several years, screening intervals can be safely extended from 3 to at least 5 years. This means fewer tests over a lifetime without reducing safety. And importantly, HPV testing also opens up a new option, self-sampling. Next slide, please. So to understand why self-sampling could be important, it helps to look at recent data from Canada. In 2024, around 1 in 3 women eligible for cervical screening were not up to date. This is an increase from about 1 in 4 in 2017. This decline is seen across all groups, regardless of age, province, or place of residence. And while overall coverage is still close to the World Health Organization target of 70%, it remains well below the Canadian national target of 90%. And as we saw earlier, increasing screening participation will be essential if Canada is to move further towards elimination of cervical cancer. Next slide, please. It is also important to look more closely at who is not being screened. Cervical cancer is not evenly distributed in the population. It is more common in vulnerable groups, particularly among women who are socioeconomically disadvantaged. At the same time, these women are less likely to participate in screening, including those in Canada. This means that improving participation in these groups could prevent a disproportionate number of cancers. And this is where self-sampling, if implemented effectively, could make a real difference. Next slide, please. So on this slide, you can see a few examples of self-sampling kits used for HPV testing. Having different options is important, because it allows women to choose what works best for them. We now have strong evidence that women generally find these kits easy to use. They also value being able to avoid a speculum examination, which some women find uncomfortable or painful. Self-sampling is often seen as less embarrassing, more convenient, and easier to access, particularly in more remote areas. In other words, self-sampling can make screening more accessible and more acceptable, especially for those who are less likely to attend traditional screening. And clinical studies consistently show that offering self-sampling specifically targeted to underscreened women leads to about 1 in 5, or 20%, taking part. In practical terms, if current coverage with clinician-collected samples is around 70%, as we saw on one of the previous slides, and 1 in 5 of the remaining 30% non-participants would participate through self-sampling, then overall coverage could increase to around 76%. Next slide, please. So we also see that targeted offers of self-sampling work with non-attenders, not only in research studies, but in routine care. And for example, the capital region in Denmark introduced self-sampling in 2014, initially as a pilot within routine screening. The pilot targeted women who were at least 1 year overdue and invited them to order a self-sampling kit. This is often referred to as an opt-in approach. Around 1 in 3 previously non-attending women took part. Of these, about 2/3 used self-sampling, but surprisingly, about 1/3 chose to attend clinician-based screening instead. Participation was higher among women who had missed screening occasionally, but even among those not screened for 10 years or more, uptake was still meaningful. When self-sampling targeted at non-attenders was fully rolled out across the region from 2017 onwards, results remained very similar. The region also briefly tested an opt-out approach where kits are sent automatically with the invitation letter. This led to a small additional increase in participation, but overall, both approaches targeted at non-attenders improved screening uptake. Next slide, please. In many countries, self-sampling is now being offered to all eligible women, rather than only to those who are underscreened. The idea is that this could have two effects. First, it may increase participation among underscreened women, even without specifically targeting them. Second, women who already attend screening may choose self-sampling instead of clinician-based testing. This could make their screening more convenient, reduce the burden, and free up time in primary care. In other words, this approach could both increase participation and transform how screening is delivered. This has never been tested in formal trials, but fortunately, we now have real-world evidence from early adopters of self-sampling for all, including countries like the Netherlands, Sweden, Australia, and New Zealand. And in the remainder of this talk, I will use these examples to explore what we can learn about wider implementation. Next slide, please. So to understand how self-sampling transforms screening, it's important to see cervical screening as a process, not just a test. This process has several key steps. First, all eligible women need to be identified and invited, and screening should be easy to access and ideally free of charge. Second, participation needs to be as high as possible, especially among more vulnerable groups. Third, samples need to be tested with accurate methods such as HPV testing, which can reliably detect early changes. And finally, women with a positive HPV result need to receive appropriate follow-up. And with this in mind, let's now look at data from our 4 countries to see how well self-sampling has changed cervical screening. Next slide, please. So let's first look at how screening invitations are organized in these 4 countries. In Sweden and the Netherlands, population-based invitations, meaning that women are automatically invited based on age and residence, were already in place, along with free screening well before self-sampling was introduced. Australia strengthened its invitational system in the previous decade. Screening has long been publicly funded through Medicare, although some out-of-pocket costs remain, but there have been no major recent changes to this model. New Zealand is somewhat different. An organized screening program has existed for a longer time, and some cost reductions had been implemented at least regionally. but more systematic invitations and broader, more clearly defined free access for priority groups appear to have been strengthened more recently, more or less around the same time as HPV testing and cell sampling were also introduced. And this distinction will be important when we interpret the changes in coverage on the next slide. Next slide, please. So these are population level data on screening coverage reported directly from national screening programs. Across these 4 countries, we see that most women are now using self-sampling for cervical screening. So self-sampling is incredibly popular. But much of this seems to reflect a shift among women who were already attending screening, moving from clinician-based tests to self-sampling. As a result, overall screening coverage has changed very little in most countries, and this suggests that increase among previously underscreened women has likely been modest, because if it had been large, we would expect to see a bigger rise in overall coverage. But again, you see New Zealand is different. Here, coverage increased more substantially from 67% to 75% in just 3 years. But as we discussed on the previous slide, several changes to the program coincided with self-sampling, including further improvements to invitations and access. So though self-sampling may have helped, it is difficult to attribute this increase to self-sampling alone, and I certainly would welcome further studies to better understand what is driving this increase, because I'm sure that there will be valuable lessons in there for all of us. Next slide, please. So on the previous slide, we saw that increasing coverage in New Zealand has increased. We saw that the coverage in New Zealand has increased substantially over the past 3 years. And you can see the same trend here on the left. Given this increase, it's important to look more closely at who is benefiting. The figures in the middle and on the right show the same data, but broken down by ethnicity and level of deprivation. The encouraging finding is that the largest increases have been seen in the most deprived groups and among ethnic minority populations. But despite this progress, substantial inequalities remain, and the gap in coverage between the most and least deprived groups is still around 20 percentage points. For example, while coverage among those least deprived is 86%, it is only 66% among the most deprived. Next slide, please. So overall, these data from 4 countries suggest that self-sampling alone is unlikely to increase screening coverage to national targets or fully close existing inequalities. In Canada, barriers are not only about access. Women also report low awareness, not being offered screening by their provider, and they exhibit irregular participation over time. Now, I'm not aware of detailed Canadian data on why previously screened women stop engaging, but international studies suggest that practical barriers and negative past experiences may both play a role. And so all of this points to a broader need to continue investing in raising awareness, ensuring women are well informed, designing services that meet the needs of more vulnerable groups, improving access and capacity within the healthcare system, and supporting providers to recommend screening consistently. If these elements are in place, then self-sampling may be better positioned to make a more consistent and larger impact on population-level coverage. Next slide, please. So let's now move to another key part of the screening process, and that's the choice of test. HPV tests were originally developed and calibrated for samples collected by clinicians, and are now being repurposed for self-collected samples. Early studies suggested that self-sampling performs just as well as clinician collection. But we need to be careful in interpreting these results because much of the evidence comes from women who already had abnormal cytology. And the key question is whether self-sampling can reliably detect early pre-invasive lesions in routine screening, both in those with normal and abnormal cytology, not just in higher risk groups. In reality, some women with pre-invasive lesions have no abnormalities visible on cytology. These samples are different, and it is more challenging to detect early changes in this group. This matters because improved detection of pre-invasive lesions that present with normal cytology is the reason why we switch from cytology to HPV testing and allows us to safely extend screening intervals. Next slide, please. And unfortunately, there is still limited evidence on how well self-sampling performs in women who have no cytological abnormalities in screening. The data we do have are not perfect, but they suggest that HPV testing on self-collected samples may miss around 10% of early lesions that would have been detected in clinician-collected samples. And because of this uncertainty, the American Cancer Society has recently recommended a more cautious approach. When self-sampling is used, they suggest to repeat screening more frequently, meaning every 3 years rather than every 5 years, as is typically done with clinician-collected samples. Next slide, please. So communicating these differences is challenging, especially given the limited evidence. When women are offered a choice between clinician-based screening and self-sampling, they need to understand that these options may not be entirely similar. But the message also needs to be tailored. For women who would attend clinician-based screening, switching to self-sampling may mean choosing a slightly less sensitive test. For women who would otherwise remain unscreened, self-sampling is still a major improvement, even if it is not perfect. So communication needs to reflect this context and be clear, consistent, and acceptable across different cohorts. This is likely to require input from both experts and the public. Next slide, please. So even though communicating these differences can seem challenging, recent but currently unpublished data suggests that it may be more straightforward than we think. A 2025 Access survey across 4 countries, including Canada, recruited nationally representative samples. In Canada alone, 1,000 women took part. Participants were shown 2 short statements explaining that self-sampling may be slightly less sensitive and could miss some early changes, using different wording for each statement. But regardless of how this was phrased, around 9 in 10 women found the message clear and easy to understand, 8 in 10 found it helpful for decision-making, and 8 in 10 felt more informed. So communicating differences in test performance does not necessarily need to be complex as long as the information is shared clearly. Next slide, please. And so finally, let's look at what happens after an abnormal screening result. All 4 countries have national guidelines that define how women should be followed up. These guidelines include when additional triage tests are needed, how they should be evaluated, and when women should be referred for further assessments, such as colposcopy. They also set out who is responsible for monitoring that follow-up takes place and how it is funded. Next slide, please. Data on follow-up are still emerging, but a few patterns are becoming clear. Around 8 in 10 women with a positive HPV test attend follow-up testing when asked, and another 1 in 10 attend with some delay. This means that the remaining 1 in 10 HPV positive women who choose to be screened with self-sampling might miss any further follow-up. There are also some differences in what happens after the triage test, depending on how women were initially screened. For example, in the Netherlands, about 95% of HPV positive cytology negative women who were screened by a clinician, they returned for repeated testing, compared with around 85% of those who used self-sampling. There seem to be at least in the Netherlands, no major differences in attendance for colposcopy, but the gap, it looks like it is increasing at colposcopy following repeat tests. Next slide, please. So how should we summarize these findings? First, strong screening systems remain the foundation of everything. This includes population-based invitations, clear national guidelines, consistent practice, and sufficient capacity. We also need to continue investing in awareness, education, and engagement, especially with more vulnerable groups and those who do not respond to invitations. Clear and tailored communication will be essential so that all women can make informed decisions regardless of their background. And at the same time, Cell sampling should complement the current practice, making sure that a high-quality clinician-based screening service remains accessible. HPV testing allows us to safely extend screening intervals, but only if follow-up is well organized and women are supported to attend. Because there is still some uncertainty around the sensitivity of cell sampling, we may need safeguards, for example, in the form of shorter screening intervals. And once we have better evidence showing that cell sampling really is as sensitive as clinician sampling, those safeguards can be removed. And finally, ongoing data from real-world implementation will be crucial to refine cervical screening over time. Next slide, please. This is just to say thank you very much for your attention, and I'd be happy to take your questions. Thank you.
Thank you, Mateka. That was a very informative discussion. I am so excited about the evolution of HPV screening. It's so important that we turn that trend around and make sure that, well, in this case, all across Canada, we start to get that trajectory in terms of screening going up and deaths going down. So thank you very much for that. Mateka invited questions. Please put them in the question link on the webinar, and we will get to them at the end. Our next speaker is Teresa Norris. Teresa is an internationally recognized researcher, advocate, and sexual health expert. She is the founder and president of HPV Global Action, as well as president of the Quebec Cancer Coalition. With over 25 years of experience in cancer prevention and policy, she leads global initiatives to improve oncology outcomes and expand equitable access to care, including major international collaborations focused on cervical cancer and global health. Please join me in welcoming Teresa. Take it away.
Thanks so much, Carmen. It's great to be with you all today, and I'm here to share some recent partner experiences that are going to help us inform how we should be rolling out cell sampling implementation across Canada. So I'd like to first start off by saying I'm joined by these very important organizations that without all of us working together, we never would have had the success that we've had in launching this entire pop-up clinic approach. So thanks to my partners and the collaborators for making this whole initiative possible, of discussing how we rolled out the beginnings of pop-up clinics across Canada. So first, we know that HPV tests are not available everywhere yet. There are many clinics and regions that are across Canada that are still doing their cervical screening using Pap tests or have not fully rolled out their HPV testing yet. HPV testing is not being offered proactively everywhere to patients that are coming to clinics for cervical screening. So a lot of places around the country, there's a promotion for women and people with a cervix to be asking for it. This is also a topic that we're empowering people around the country to be asking if they can be getting reimbursed by their insurance companies. Some are reimbursing, so it's important for people to check out their individual insurance plans to confirm their personal coverage on reimbursements for HPV testing in the places where it's still not being rolled out with public funding. This is a quick snapshot of Canada right now. This was a look at it at the end of 2025, looking across from the west to the east. And as we can see, it looks very different. It's quite eclectic what cervical screening looks like across Canada, where BC is at on transferring over to doing HPV testing as their screening modality is not where on the other end, 8,000 kilometers away, where Newfoundland is at. So there's still quite a bit of work to be done across Canada before we've all completely transitioned over to doing our cervical screening with HPV testing. So why did we do this initiative? This whole pop-up clinic campaign approach was really launched over one simple concept, that cervical cancer is preventable with regular cervical screening. This is something that we all know. And we also know that there are many individuals across Canada that are facing important barriers to access, as Matika highlighted. There's many reasons why people are not getting screened, and there's a lot of different types of barriers across Canada. So January is the Cervical Cancer Awareness Month, and so this year we wanted to take that opportunity to act and to launch on a dedicated day or time frame and use that month of cervical cancer awareness in January to really kickstart this whole concept of a pop-up clinic approach. And here to the right side of your screen is just some of the different advertising that we use during the promotion. So the pop-up clinic campaign, the idea in our role of the organization HPV Global Action was first we work with clinics quite commonly across Canada already, and we reached out to a lot of these clinics across the country to present this opportunity to participate in this initiative. So at first it was literally just picking up the phone and calling a clinic and letting them know, hey, it's the month of cervical cancer awareness this month. Are you interested in getting involved in an initiative? So we provided this concept to the clinics. We offered them educational materials, promotional assets that included posters and messaging. We had t-shirts and different types of promotional materials. And then we were also offering that any clinics that needed to have supplies, that Hologic would be able to support them through those supplies for their cervical screening that they would be doing in their pop-up clinic. So we offered the same concept very simply. And so we had a champion within the organization that really just picked up the phone and regularly was calling clinics all across Canada. That was our first step. And then how it worked is the clinics then selected a date and a time based on what worked for them. And that looked very unique in each of the parts of the country. We had clinics that decided to do it on weekends. There was other clinics that decided to do it in evenings. There were clinics that decided to set a room aside and have staff that were specifically dedicated throughout the day of their regular operating hours. We didn't get specific with any of the clinics, and we really left it up to them to select a date. We were earmarking, particularly the end of the month in our launch, and so we kind of were saying, oh, if we could get this together for the end of January, that would be great. And so they all aimed to either pick a date at the end of January or soon after. And it was really the key was what worked for that specific clinic. Then those clinics, they did their advertising locally with their populations in the regions that they're serving. And it was really just to promote that they were hosting a free cervical screening day. And this was also open to the public that didn't necessarily have any type of link to those clinics. So it was really opening up that opportunity to people that potentially had never even been to any of these clinics before. And on our side, HPV Global Action, we supported all of these promoting that was being done across Canada with these screening days through all of our social media and our networks as well. And then the impact, and I'd say the lessons learned, we went from being a one-day event to some of our places have ongoing programs. That's first. So we've had clinics that have expanded beyond this initial event. So it started off as just being, a pilot, if you wish, you can call it that, of what could a pop-up clinic approach look like. So they were really just aiming on having one specific pop-up clinic opportunity. And now there are some places that have scaled up and are now offering regular screening days. In total, we were able to have 6 clinics across Canada. We had 1 in Alberta, we had 2 in Ontario, and 3 in Quebec. And below, I listed some of the examples of clinics in these different provinces that have now turned this into something that they're offering on a monthly basis. The biggest lessons learned, it's easy to initiate. Action is really what the key step ended up being, having somebody that was motivated with a clear and simple plan that was flexible, and just making that their dedicated task to reach out to everybody and give them that same opportunity. Then we got to see that clinics will run with a good idea everywhere. As soon as they saw that it was easy to launch and that there wasn't a lot of requirements, they were very quick to jump aboard, and most of them had all of what was necessary to do this themselves. So they were really excited about the materials that we were offering them and that we had posters and the capacity to support promoting, it really helped them to rally around this good idea. And we got to see that small initiatives can create lasting change. We had quite a bit of success here in Quebec. Here's just some snapshots of some very motivated healthcare professionals around the country that participated in this initial pop-up campaign. You can see their t-shirts. Everybody was really excited about just having this whole concept that we were rallying around. And we're very excited to be able to do this launch. Some of our partners provided quotes as well, so that we could do a news release. Our Carmen, who's moderating today, provided a quote: "We have an opportunity to end cervical cancer by focusing on HPV screening and follow-up. We need to be raising awareness and work with diverse healthcare professionals to reach women where they are." From our Society of Gynecological Oncology of Canada, their quote was, "Improving access to cervical screening across Canada is key to ensuring everyone has a fair chance to early detection and preventing cervical cancer." And I think that's the huge takeaway message. Access is turning into the key and the true opportunity that we all have to be improving access to all of our populations in all of the regions that we're serving. On that note, I'd like to thank you and anybody who wants more information or who'd like to get more involved, so that when we continue to be launching more and more of these pop-up clinics for the rest of this year and going into next year, we'd love to be having you join all of the following pop-up clinics that we plan on putting together. Thank you for your time.
Thank you very much, Teresa. Truly, the pop-up clinics were a brilliant innovation to reaching women where they are. I use that phrase a lot. I can't wait for next year, because now there is all the proof that this is a way to move us closer on the transitioning to HPV screening, but more importantly, reaching the unscreened and the underscreened, as Matika had pointed out. We really need to focus on that, and I think your pop-ups can do that, and that they're sustainable, so that's great. We're now going to move into the question and answer period. So if you haven't already put your questions in the question app, please do so. And I am just going to start from the top, and I'm going to let my colleagues decide who's best to answer each question. So the first one up is from Mark Randall. What are some of the challenges or barriers beyond knowledge that may be preventing folks from participating? I am thinking childcare, work loss, transportation, similar to folks limited HIV testing in his work. Teresa?
Yeah. The number of barriers that have been described in the literature and that we see that women experience in real life is incredibly long, and we need to find a way how to understand them and understand how important they are in each specific population, and then try to address them with interventions that are going to be suitable for that specific population or cohort of the women. Absolutely, it's not just embarrassment, it's not just remoteness, it's mundane things like not having childcare, not having time off work. But we do see that also these kind of barriers are getting more and more addressed, especially by various patient advocacy groups who are, for example, starting to work with employers to allow women to be screened during work time without losing pay. We're in very early stages of that, but I do hope that initiatives like this are going to become more and more prevalent and successful.
I think I could just add slightly to that also by highlighting, in Canada, we have a very different demographics, and we also have very different, we looked at a couple of slides back, what that looks like right now as a cervical screening opportunity based on what province that you're living in. And if we were to do a deep dive into what that invitation system looks like across Canada, I don't know if we could say there's equitable information that's being delivered to all women and people with a cervix that need to be invited and need to be informed. So I think that there are some simple things that if we started to prioritize some of the messaging, I think it would be easier for us to probably identify some of the bigger barriers that we're identifying right now. But I think one of the key things that we should start really working on across the entire country is making sure that we are aware and reaching us in ways through text, through emails, through letters in the mail. We know that these things work in similar systems in high income settings. So we should be more invested in making sure that what we're offering people in British Columbia is also what we're offering people in New Brunswick and in Newfoundland and in, you know, some of the more further regions, because I think that in itself is really going to make an improvement.
Thanks, Teresa. This question is from Caitlin. Can you explain why self-sampling is more sensitive for women who have not had regular past cervical screening and why it is less sensitive for those who have kept up with their cervical screening? Nateka, I think that one is for you.
Sure. This is because it appears so, because of the way we measure test sensitivity. It's because we're not measuring the actual sensitivity, but we look at how many of the lesions that we need to treat are detected compared to clinician-taken samples. And women who have not been screened for a long time, what happens in this kind of a population is that we have a larger stock of older lesions that have been there for a longer time. Those lesions have accumulated a higher viral load, which is going to make it easier for HPV tests, even if they're not performing very well, to detect those lesions. On the other hand, in women who are routinely screened, regularly screened once every 3 years, once every 5 years, what we need to detect is not that stock of old persistent lesions, but a newly developed lesions that are much earlier in their etiology, at which point they're still on average, they have lower viral loads and these signals to detect them within an HPV assay are less strong. And that's why the apparent difference is just because of the characteristics of the population. But even once, I have to emphasize that even for those who are previously unscreened and then they're screened with cell sampling, ideally we would retain them in the screening program through cell sampling. But that means that eventually they will become well screened as well. And even in them, we will have to make sure that we find the newly developed lesions and not just the old ones, because they will have been screened out through prior screening. It is just because of the way we're measuring these things.
So this question will build on that. Does that mean that cervical cytology is becoming a thing of the past and something that won't be a part of the regular women's health check in the future? No more pap smears?
Quite likely. That doesn't mean the end of needing to provide a sample. It just means the end of that particular procedure in the laboratory, so how laboratories need to be organized. At present, we are still using cytology. In some provinces in Canada, it's still being used as a primary screening test. In other provinces that have already moved onto HPV testing, it's now been relegated to the role of a triage test. But with the incoming cohorts of women who have been vaccinated against HPV 16 and 18, we will be seeing that the performance of cytology, no matter how well quality controlled and assured, that performance is going to become worse and worse. So the community is really advocating a move away from cytology in general.
Thank you. Are there any updates on guidelines or recommendations for vaccines? More current information, I guess, is really, and I'm going to be honest, this question was asked about a specific brand name, which I haven't included on purpose, but generally speaking, are there updates and guidelines on the use of current vaccines?
The current vaccines or screening in vaccinated women?
No, this is actually in vaccines. That was the question. And maybe we need to take that offline. I wasn't positive about this one.
I mean, just in general, we know that, let me bring it back to screening. We know that vaccinated women, they will have a substantially reduced burden of the disease. It's not going to make sense to be screening very frequently, and it's not going to make sense to start with screening very early. We would be doing a lot more harm than good if we would continue with very intensive screening of highly vaccinated populations. So we are going to see a change in the screening guidelines very soon. I think that the International Agency for Research on Cancer and the WHO are preparing these guidelines, and if not already out, I'm pretty sure that we're going to see them very soon.
Thanks. Teresa, do you want to add anything to the vaccine question?
I think the only thing that there should be added to that is I think that a lot of the parts of the country we're trying to aim at having high coverage on our vaccination rate. So it's really making sure our registries and the reporting and the surveillance that's being done in the provinces are going to be the focal point. So we want to be making sure that our school-based vaccination programs are functioning at full capacity and that we're offering equitable opportunities in all the provinces to our immunocompromised populations as well. We've got some provinces that are covering up to 26. We've got others that are up to 45. So this will, trickle into also the screening opportunity that Matika just underlined, that it's going to impact the populations that we're screening. So having high coverage is really going to be key to making sure that our vaccines are doing what we need to be doing to make sure that all of our provinces have high coverage. And we want to be having a minimum of 80 to 90, like the goal is 90% coverage. So very few parts of Canada can say that their entire province is at 90%. So I think right now the goal should be on really pushing the school-based programs, but also starting to discuss with adult populations that follow under that indication, because a lot of parts of Canada are offering that free opportunity to other cohorts, including males that have sex with males. I think it's like an underused opportunity that a lot of our provinces have and territories to be extending that vaccine coverage that will ultimately impact the screening populations as well.
Thank you for that. I think we have to remember that preventing cervical cancer involves three things: vaccinations, screening, and follow-up. And they've got to go together if we're going to put this on the no-go list.
Well, we get to add as well, don't forget, when we're vaccinating, we're not just preventing cervical, we've got 8 other cancers that we're preventing. So we have to be clear that the goal of today is to discuss screening and the impacts, but the vaccination is not a one cancer protection. We're looking at multiple benefits. So this is a wide stretching opportunity for cancer prevention through the vaccination. And a lot of us have to update our messaging, because I think that hits a lot stronger in a lot of our households that are maybe, still contemplating how much are you going to contemplate protecting your loved ones from 9 cancers through a vaccine. So I think the important message is to keep updated and make sure that our messaging is at 2026 on this topic of HPV prevention.
Thank you for indulging me and letting this drift for a moment from screening. Let's take it back there. Self-sampling versus clinician collection. If the patient has the choice, should the clinician recommend having the clinician collection over a self-collection, assuming the patient does not have a preference? Come on, ladies.
This is one I discuss with my peers quite frequently, and I see that the attitudes towards the choice are very different. And I think that it is important to allow women to have that choice, but as long as they are informed correctly about, you know, that marginal decrease in accuracy. And so it may very well be that, you know, once women are informed about that, they will be happy to take that chance, especially if they have been previously well screened and if they're very likely to come back in 5 years or 3 years. And that choice for a self-collected test will give them more benefits in terms of, you know, screening is just easier that way. But for women who are very anxious about safety, you know, the conversation should that conversation should definitely focus on the accuracy. I think that both screening tests, you know, HPV testing on clinician samples and self-collected samples are good. It's just that they're not equal. And so preferences, personal preferences should play a role in the choice here.
Thank you for that. Considering some of the concerns from screening participants about the switch from PAP to HPV, is there any data or best practices about how to communicate this so that there's more acceptance from the patient perspective on HPV as a new primary testing method?
I think it might not necessarily be where we're sitting today that people have concerns as much as they don't feel informed about what is happening. I think we saw with Australia years ago when the longest petition the country had ever seen, when they had launched HPV testing, and women across the country signed this petition wanting it to be put back to PAP tests. And that's because they're an important part of educating the country and lay populations about why this was better. We know it's more accurate, it's more precise, and this is the reason that we need to do it less often. Look at how long it took me to say that. Why do I have to wait for my patient to be all confused of why aren't you doing it so much? So I think it's about tailoring a fixed, simple, action-orientated piece of information. I think that we should be careful about who we educate and versus who we inform, and to carefully design structured, clear understanding that we're always doing cervical screening. We're always offering the best modality that's possible. And that way we're getting away from labeling things, because we know with some of the feedback that's coming back, not only just from Canada, but from other regions, some people are confusing HPV testing for an STI test. So they're feeling that this is not the same thing. We know that many populations don't know the link between HPV and cervical cancer, so they don't know that this is the newest way of doing cervical screening. So we just have to be careful that inwards facing on conversations like we're having today, we can dissect it and use all of the specific wording, but public facing, we should always be calling it cervical screening, and that we're always offering the best standard. And this is why we've switched, and we're always trying to keep it as accessible and easy for our populations to understand. So hopefully a lot of the provinces and territories are going to be working with groups like us to help them design their communication methods so that they can have quick interactions with their patients and it not inundate their appointments, because I know that that ends up being a barrier as well to explaining in some of our medical appointments with our clientele that's coming in the door. So tight, quick messaging that's information based is really definitely the way to be going, and working with professionals like all of us to help design those messaging is something that we'd like to be doing more and more.
Thanks, Teresa. Mateka, anything to add to that?
No, I fully agree with everything that Teresa said. We saw, you know, a similarly vocal campaign against the introduction of HPV screening in Wales back in 2022 when the screening interval was extended from 3 to 5 years. And I think that the UK screening programs, all 4 of them, have learned quite a lot from that lesson about the importance of making sure that your communication campaign is developed in the right way and that it is giving the right message, consistent message, and comprehensive message.
So this question is, do you think that having a national cervical screening program, such as the UK NHS, would be more effective in Canada than each province having their own program? I'm going to add to that question with some of what I'm aware of as well, where data protection laws are getting in the way and that kind of thing as well. So is it better, and how can we move towards that if that national registry is the solution?
The UK has 4 different screening programs, actually. We also have, you know, it's almost the same as provinces, except that they're called countries here. But all of these programs are, they have quite, I mean, they do differentiate in details, but they do have very similar, they operate following very similar guidelines, and there's quite a bit of collaboration between these screening programs and making sure that they're all aligned. Yeah, but it's, I think alignment between the regional screening programs is the minimum that should that should happen.
So we're running out of time. That's it. We can't take any more questions. I know the team at HPV Global Action is going to take a look at all the questions you submitted, and we'll follow up where they can as they send out the slides and the survey. I would remind you, please complete the survey. That's so important to planning what comes next. And so thank you again to Teresa and Mateka, and for everybody for joining this webinar today. We really appreciate the support of Hologic that allowed us to bring this webinar to you, again, at no cost. I will repeat again, please do the evaluation. The webinar has been recorded, and the video recording and slide set will be available on CIDC's and HPV Global Action website. So that was my mistake, not sending out to you, but it will be available in the coming days, so you can watch for that. And there are other resources available on both websites. And I think a clear message that came through today is that there are organizations working together to do this better. And you should be encouraged to connect with them when you have an innovation, a solution, an idea, or a question. We need to work on this collaboratively. So any final comments from our guests, Teresa or Mateka, before we wrap this up?
We hope that everybody gets involved in wanting to have more pop-up clinics. We don't have to wait for January of next year to get started. So anybody who's interested and wants support, let us know.
Excellent. Mateka?
Exactly. Widening access, making it easier to access screening services, I think, is the key, whether that's through self-sampling or any other interventions.
Excellent. Well, thank you, everybody. Let's put cervical cancer in the history books as something that no longer exists by working together. So thank you very much, and I hope to connect with you all again soon.